Good evening, and thank you for joining us tonight. My name is Nicole Silva, and I'm a member of our strategic engagement team here at University Relations and UC Santa Cruz. Our University Forum series focuses on the relevance of our research to the community and to social, economic, environmental, and political issues. The University Forum proudly features the impact of research conducted by the faculty of UC Santa Cruz. Tonight's speaker is Professor Matt Sparke, speaking on the lessons of COVID for the global and community health. Before we begin, I would like to share a few details about the event tonight. We are using a webinar tool, so there is no chat function. We will have the opportunity to answer your questions at the end of the program, and we invite you to submit your questions into the Q&A box at any time. And lastly, tonight's event will be recorded. We would like to thank the Institute for Social Transformation here at UC Santa Cruz for co-sponsoring tonight's event. This fall, UC Santa Cruz will be launching a new global and community health program, which is aimed at addressing challenges of ill health both globally and locally. Both a Bachelor's of Arts and a Bachelor's in Science are being developed in global and community health, alongside new efforts to advance health-related research initiatives that bring together faculty from all 5 divisions of the university. One of those faculty members is also Associate Dean of Health, Wellbeing, and Society, Professor Nancy Chen, who will be giving us an update on the work the Institute is doing, as well as introducing tonight's speaker. Nancy Chen is a professor of anthropology here at UC Santa Cruz. She is a medical anthropologist, and her current research explores the study of healing narratives, chronic and infectious diseases, traditional medical knowledge, and intersection between the body, politic, gender, ethnicity, and medicine. Welcome, Professor Chen.
Great, thank you very much for inviting me tonight, and I'm looking forward to this important conversation. I've been fortunate to work with Professor Sparke and other faculty for several years to launch the Global and Community Health Program, and we look forward to welcoming 8 new faculty with leading global health research in the social sciences and the physical and biological sciences division this coming year. I'm also a faculty affiliate for the Institute for Social Transformation. The Institute has been supporting the development of global community health, specifically helping to incubate research activities and coordinate collaborations. Global community health constitutes an urgent area of research, study, and practice. Our interdisciplinary program prioritizes the improvement of health and well-being in communities worldwide. Building on collaborations across departments, divisions, and the community here in Santa Cruz, we seek to address forces affecting health outcomes that range from the molecular, ecological, and genomic to the global, political, and economic. Ultimately, our goal is to support the sustainability of communities and climates for health, both locally and globally, doing so in ways that cultivate a new generation of global and community health leaders. And it's my great pleasure to introduce a dear colleague and incredible collaborator in the Global Community Health Initiative. Matt Sparke is a professor of politics at UC Santa Cruz. Originally from Tunbridge, England, he moved to North America for graduate work after completing his BA in geography at the University of Oxford. He joined UCSC's politics department in 2017 after 22 years at the University of Washington, where he held joint appointments in international studies and geography, and also helped create and direct new undergraduate programs in global health and integrated social sciences. His most recent article, entitled Contextualizing Coronavirus Geographically, was just published in May by the Royal Geographical Society and offers 7 frameworks to understand COVID in relationship to wider global forces. Professor Sparke has authored over 100 other academic publications, including the books In the Space of Theory and Introducing Globalization. He also has multiple awards for teaching, including the Lifetime Distinguished Teaching Award at the University of Washington. Throughout his career, Professor Sparke has taken an interdisciplinary approach to curricular development with his interests in political theory, global studies, and global health. And it's these same interests that he now brings to the collaborative work of creating a global and community health program here at UC Santa Cruz. We'll now go to Professor Sparke's presentation.
Well, thanks so much for that very generous introduction, Nancy, and a big thanks to all the organizers and university relations for setting up this talk and inviting me to do it. So it's a really big honor for me. And I feel like it's part of the warm welcome I've received at UCSC ever since moving here from UW. I'm very grateful to all the colleagues, including Nancy, that I've met since coming here. And I'm also very grateful to lots of staff and many people in the community and our students. So those of you who've joined for this evening, I hope I can make it worth your while and that this presentation is worth your time. I'm going to turn now to sharing my screen and a PowerPoint. So bear with me as we try this. Okay, and Nancy, can you give me a thumbs up if you can see that okay? Hey, wonderful. All right, so the title of my talk is The Lessons of COVID for Global and Community Health. And you may be wondering at the outset, who are these lessons for? So my talk's basically organized in two parts. The first part, the longer part, concerns the lessons for humanity globally, which sounds very grand, but my particular take on it tonight builds on my work on globalization. I've always been interested in my work on globalization, on how inequalities are structured into all the interdependencies, all the interconnections of globalization, and how those inequalities have come with insecurities, but also with pushback and protection of communities. So I'm bringing those interests to the lessons of COVID and interpreting those lessons of COVID, of the pandemic, in relationship to that pre-existing work on globalization. So I'm particularly interested in the inequalities amidst the interdependencies of the disease. COVID as a disease, it thrives on our interdependency as a human host. And obviously it's spread around the world very effectively through our global interconnections. But it's not a flat world that it's spread through. It's spread through all kinds of crevices and inequalities created through, in, and with our interdependencies. And those are some of the inequalities I want to address empirically with some data to share with you here. Data that points to the way that COVID has at once exploited as well as exposed inequality in our societies locally and globally. I'm interested in how insecurity comes with our attempts to use national security measures and national securitization to respond to COVID. And I'm also interested in highlighting some of the ways in which the disease has brought out the best in people, brought out community and protection and care amidst all sorts of signs of cruelty, rejection, and xenophobia. I want to turn from that those illustrations of community then to some of the lessons of COVID for us locally here at the university as it relates to our university community partnerships and how we can keep building those, how it relates to our education initiatives and the two new degrees that we're planning to develop and roll out through the course of next year. A lot of approvals have to be put in place for that to happen. I'm going to talk about some of the ideas behind the BA and the BS at the end of the talk. And I'm also going to highlight the terrific array of talent that we have on the campus in terms of research relating to global and community health. Research that does illuminate key questions around COVID. Some of you may have already seen Marm Kilpatrick's talk, but he and others are continuing to offer great insights into COVID and I'll flag some other people towards the end of the talk. Lastly, I want to give a shout out here on this slide to one of our undergraduate students, one of the many undergrads who've become interested in the possibilities of a global and community health program on campus. Her name's Cora Fortune, and she drew this wonderful logo for our nascent program with the Santa Cruz slug coming out in front of a banner saying Fiat Health, and gently, caringly carrying a image of the globe. So I get back to the UCSC side of things at the end. To begin with, though, I really want to remember the reality, the deadly reality for so many people of this disease. It's not just numbers, it's not just an academic issue. Many of you may have friends or relatives who've been hit by the disease. It's not that far away from us, and lots of good people are dying from it. We need to remember their passing. Here's just an example of one simple obituary in an Arizona newspaper just recently. And I want to flag it here because not only does it mark the passing of ordinary people with an ordinary obituary, but simultaneously, it's a call for political awareness. So you can see here, I just want to move something on my screen so I can read this. You can see here that the relatives of Mark Lucrezia, whose death is being marked in the obituary, write this: Mark, like so many others, should not have died from COVID-19. His death is due to the carelessness of the politicians who continue to jeopardize the health of brown bodies for a clear lack of leadership, refusal to acknowledge the severity of this crisis, and inability and unwillingness to give clear and decisive direction on how to minimize risk. There's real rage and concern here, and it speaks directly to the first set of inequalities I want to highlight for you all. Relating to the racialization of death due to COVID. We keep hearing that we are all in this together as human beings, and I don't want to pour scorn on that call for collective awareness. I think it's really important for thinking through a collective global response to the disease and the very urgent need to develop herd immunity at a global level. But while we say we are all in this together as human beings, we have to remember that our unequal conditions of being human are leading to vast variations in vulnerability, damage, and death. This is inequality amidst interdependency. African Americans have been dying at a rate of about 5 times that of white Americans. Native Americans have a death rate that's about 5 times that of white Americans. And Latinx and Hispanic Americans have a death rate that's about 4 times that of whites. This is all from CDC data from June 2020, data that we hope very much that the CDC will be able to continue to collect and disseminate. Analyzing this data, the Brookings Institution has highlighted that these racialized gaps in COVID death rates are actually even worse if you look at it in terms of age cohorts. So if you go down to people living in their middle ages, 35 to 40 years old, 45 to 54 years old, you see that the ratio of African American or Black deaths to white deaths is 10, and that of Hispanic and Latino deaths is 8 times that of white deaths. So there are huge racialized gaps in the middle of the age spectrum. Not surprisingly, those same racialized vulnerabilities show up in hospitalization rates as well. So Native Americans are being hospitalized at much higher rates per 100,000 of population. African Americans higher too, Latinx higher too. to whites at 40.1 per 100,000. And here are the cases. So we've done deaths and hospitalizations, and here are coronavirus cases per 10,000 people by age and race, according to CDC. Again, you see the much higher caseloads amongst Black and Latino populations in America. Another kind of inequality amidst interdependency that's become particularly pronounced amidst COVID is in Indian country. Native people are only 10% of New Mexico's population, but more than 55% of its COVID cases. Native people are 3% of Wyoming's population, but more than 33% of its COVID cases. And the Navajo Nation has the highest per capita infection rate in the United States, 2.3%, greater than that of New York, the worst hit state thus far, 1.8%. The Center for American Progress looks at these statistics and says in a great report, a sobering report, that this represents a devastating harkback to the weaponization of pathogens as a genocidal tool in the original settler colonization of the continent. It's not a deliberately genocidal attack now, but many things explain the higher risks facing Native Americans. Things that relate back to the history of genocide, indeed. Pre-existing conditions for Native Americans that may put them at particular risk include higher rates of diabetes, asthma, heart disease, cancer, lower respiratory disease, hypertension, and PTSD. But there are also other more practical pre-existing conditions. 13% of Native Americans lack safe water and sewage disposal. Economic vulnerability is hitting Native Americans too. The casino closures are hitting tribal incomes and funding for health services. And meanwhile, their political vulnerability in contemporary America has limited assistance that they've received. Bureaucratic holdups have delayed access to funding promised in the CARES Act. Their authority to enforce shelter-in-place orders, including an example here in California by the Yurok tribe, has been flouted by non-native neighbors. And they've frequently been treated as sub-citizens. The worst, most egregious case, perhaps, Seattle Indian Health Board was sent body bags when it asked for more medical supplies to fight COVID-19. For Latinx and African American communities, there are also extreme exposure risks that they endure in these so-called Petri dish spaces. Petri dish spaces like not cruise ships, but crowded farm worker housing, meat packing plants, homeless camps, care homes, and notably here in California, prisons. Now, when it comes to explaining these patterns of vulnerability amidst interdependency, it's important to offer explanations, not just to state the inequalities. And the reason why is that a lot of bad explanations are being offered. Here's State Senator Stephen Huffman of Ohio. Could it be, and this man is a doctor, he said, could it be just be that African Americans or the colored population do not wash their hands as well as other groups, or wear a mask, or do not socially distance themselves? Could that be the explanation of why the higher incidence? Well, the answer to Senator Stephen Huffman is no, these are not good explanations. What we need instead are critical intersectional explanations that look at how multiple factors come together. There are the exposure risks I've already highlighted, and Latinx and African American workers are particularly overrepresented in the so-called essential occupations, where they can't, unlike someone like myself, work easily from home. There are also the spatial risks they face of living in multi-generational homes, often with less living space, less green space, and less access to clean water. There are heightened pre-existing medical condition risks, medical conditions like diabetes, hypertension, obesity, and asthma. And those pre-existing medical conditions have pre-existing social conditionings, or so-called social determinants of health, that have made them the medical reality that they are. Structural racism, economic deprivation, chronic malnutrition, all help explain these pre-existing medical conditions and thus the risks. Access to quality medical care is also very uneven and often limited for African American, Latinx, and Native people. Hospitals they frequent are often worse and often offer less beneficial care. There are inequalities, of course, also in insurance access. And then medical decisions, often these algorithmic decisions that big hospitals are now using, tend to curtail treatment for the poor and people of color based on algorithmic decision-making choices for physicians. In addition to these kinds of structuring explanations of vulnerability, we also, in the context of COVID, have to think about the racialized damage done to people's ability to bounce back after trauma, done to their what's sometimes referred to as resilience. That's bouncing back after a hit. If you are faced with a medical hit on top of ongoing police brutality and blame the victim stereotyping from the likes of Senator Huffman, then it does damage to your ability to bounce back, to be resilient. And there are economic hits to resilience too, to bear in mind. Black and Latinx populations are facing many more bankruptcies, much more unemployment, and ongoing job insecurity amidst the crisis. Our colleague here at UCSC, Rob Fairley, here in economics, has highlighted these vulnerabilities in relationship to self-employed business owners. Now, these ownership rates have taken a hit across the board in the United States, and Rob's June 2020 report shows a 22% fall off in business ownership by small business owners on average across America. But the fall off for African Americans is negative 41%, and for Latinx populations, negative 32%, and for Asian populations, negative 26%. The heightened economic vulnerabilities there. Beyond the economic sphere, if we turn to sexual and gendered forms of inequality, there are inequalities there. In the COVID pandemic has seen intensified intimate partner violence, or IPV, or spousal abuse. There have been spikes in calls to IPV helplines. There have been increases in murders due to intimate partner violence, and women facing intimate partner violence have seen their avoidance options, their escape options, severely limited by the COVID lockdowns and the lack of social connections that are possible. Eve Valera has highlighted in The Lancet that as a result, IPV is kind of a co-pathogenic global pandemic of its own. It works in conjunction with the COVID pandemic to cause suffering and indeed death for some women. And this isn't just a US problem, it's a global problem. I've highlighted this here with a public information diagram from India, from Karnataka, highlighting some of the numbers around women being trapped at home facing IPV. This links in turn to other global hotspots and risks. Places like refugee camps, conflict zones, the mega slums of the global south are all high-risk hotspots for COVID taking off. And related to global health research, the other big global pandemics, TB and AIDS in particular, are risk exacerbators for COVID. People suffering from TB, which is, by the way, is a disease that kills over 4,000 people a day already. but it's a disease that affects the respiratory system, obviously, and it's a disease that makes people extremely vulnerable to COVID. There's a great deal of fear that when COVID takes off in India, as it is doing now, with over 1 million cases now in India, and India ranking behind the US and Brazil as the highest number of cases in the world, the TB is very much concentrated in India too. And there's very great fear about it taking off in the Indian TB population, according to the Stop TB Alliance. AIDS also compromises people's immune response, and people living with HIV on antiretrovirals face extra dangers from COVID. As a result of these global risks, the UN Secretary General, Antonio Guterres, has said that the pandemic is like an X-ray revealing inequality at a global scale. He's also said that the economic fallout from the coronavirus pandemic could lead to historic poverty and famine. One other example of inequality amidst interdependency, which I'm going to touch on before turning to national security issues, concerns access to vaccines and medicines. On one side of this unequal picture, we see excited stock market reports from investors hoping to make money from breakthroughs in COVID vaccines and COVID treatments. Moderna's stock extends rally as experts await details of the coming phase 3 study of the coronavirus vaccine candidate. We've also seen recent headlines around AstraZeneca and its Oxford partnership, and Inovio Pharmaceuticals, Pfizer. And there are all sorts of excited stock market commentaries one can find about which drug company to bet on if you want to make a fortune out of COVID. The other side of this picture, of this very unequal picture, is the threat posed to global health by the patent monopolies that these companies are hoping to profit from. And one of the global action groups that has been most outspoken in critiquing the danger posed by global drug monopolies is MSF, Médecins Sans Frontières, or Doctors Without Borders. When they won the Nobel Prize, Nobel Peace Prize, for their work in conflict zones, providing health to war victims, they took that money and created a program called MSF Access. And I want to show you a short video now from MSF Access that makes the case much better than I can about how we need to attend to this flip side of unequal access alongside all these excited announcements about vaccine profits. So I need to share a different screen, so bear with me while I switch to the other screen that will allow me to show you this video. Now remember, this is an action group pushing for global policy reform. So it's trying to make a political point here, but it also, I think, makes an intellectual point about the problems with inequality amidst interdependency.
We're in the middle of an unprecedented global pandemic, and some pharmaceutical corporations appear already gearing up to make huge profits from it. What's wrong with that? Well, if life-saving tests, treatments, and vaccines for the coronavirus are developed, but only the wealthiest can afford them, that means everyone else will have to go without, meaning more people will get sick and die, and it will take much longer to end this pandemic. So, what can be done about it? Well, drug corporations can certainly do something about it. They can commit to not seek nor enforce patents on any medicines for COVID-19. This is important because patents stand in the way of generic, lower-cost versions of the drugs being made. And when only one company produces a drug, that vastly limits the available supply and drives up prices. Now, if Big Pharma won't do the right thing, then governments can do something about it. Governments must stand up to these corporations and override patents or not grant them to begin with. That way, many more people can benefit from needed treatments or vaccine. And we can all do something about it. Please join MSF to demand that corporations not seek nor enforce patents on any tests, treatments, or vaccines for COVID-19. Let's make sure that people all over the world can benefit from life-saving innovations. Doctors Without Borders knows what's at stake. We've seen the impact on sick people in low-income countries of drug companies profiteering. We've seen it happen to our patients with tuberculosis, and certainly with people living with HIV. As MSF, we know what it means to not be able to treat sick people in our care, not because there isn't any treatment, but because the drugs are simply priced out of reach. We can't allow this to happen with COVID-19. Not again. So pharmaceutical corporations and diagnostic companies, do the right thing. Don't seek or enforce patents on any tests, treatments, or vaccines for COVID-19. Don't even try profiteering from this pandemic, because COVID-19 will not be over until it's over for everyone, everywhere.
Okay, let me go back now to my PowerPoint. Okay. And so I think that makes the case very well about the need for global access to the vaccine. And I'm going to come back to that in a moment. But I want to end this slide by talking about one other case of treatment being limited. In this case, by the Trump administration trying to advance the security of United States citizens by securing the world stock of Gilead's drug, remdesivir. Gilead, another company that's seen its stock price go up thanks to this treatment being used for COVID. And on the face of it, this is about US national security, this move by the Trump administration. But of course, what it's also doing is jeopardizing access to remdesivir globally. And this is just one example of the wider problem with the ultra-nationalistic turn in national security planning around the world under leaders like Trump, but also Bolsonaro, under Putin, Boris Johnson in the UK. What I see these figures as doing in various ways is unmasking the failures of nationalistic securitization approaches. Their tendency is to blame migrants, to blame foreigners, to blame global agencies like the World Health Organization, which Trump has announced he is pulling the United States out of. An announcement, by the way, which Richard Horton, the editor of The Lancet, called a crime against humanity. Their tendency at the same time is to reject refugees, to reject global expertise, and to reject any kind of global cooperation. When you're facing an interdependent global problem like COVID, these are not good policies of securitization, the policies that increase risk at a global scale. Now, driving it are a number of different forces. It's not just about old national security interests. I think a good case can be made that masculinism and militarism are involved in an intersectional explanation of this nationalistic kind of securitization. A meme going around the internet has this juxtaposition of the countries most affected by the coronavirus being countries led by these men on the top of the image here, the US and Brazil and Russia at the very top. And the countries being recognized as having managed the crisis best, Germany, Taiwan, New Zealand, Iceland, Finland, Norway, and Denmark, being on the bottom, but all being places led by women. There are clearly dangers to militarizing the public health response in a masculinist, gung-ho kind of way of talking rhetorically about fighting the virus as warriors and using weapons like bleach thinking of like an attack on the virus as something that's direct in that kind of way leads to a kind of a mistargeting of action. It seems to be combined with, at least in the US context, with ideas about survival of the fittest in a kind of global competition for survival. And at the same time, interestingly, it's combined with calls for sacrifice in the war against the virus, sacrifice for the sake of the national economy. I won't show you this video, but there's a link here to a Late Show video that Trevor Noah put together, sort of compiling war talk about the virus. And it's very telling, and I leave the link there for you to go back to later on. What I want to segue here to, though, is another feature of this national securitization discourse that we're seeing being driven by what might be called authoritarian neoliberals, but people who are very market fundamentalist, but also like Trump, prone to extreme ultranationalism at the same time. Their commitment to market fundamentalism definitely seems to have hindered their response to COVID. The University of Oxford's School of Government has an interesting set of tools on their website and a report on the variation in government responses to COVID. And what it shows is that the stringency of government responses has been implemented at different speeds in different places. And both in the UK and in the United States, the stringency of the response has effectively been behind the curve of the virus. Whereas in China, in France, in Italy, and South Korea, the stringency of the response has been more ahead of the curve. This difference is partly accounted for, according to my colleague at the University of Oxford, Danny Dorling, who's a geographer and a political economy theorist, who has drawn these remarkable kind of death spiral diagrams that are available on his website for his new book, Slow Down. And what they show is the rate of deaths per day on the x-axis and the average number of deaths per day on the y-axis over time. And basically, you get a sense from these charts of how quickly a country is able to go from increasing deaths to decreasing deaths back in this direction, and thereby reducing the number of deaths per day. And the bigger the arc of the spiral, the more the damage that is done. And on this chart, both the UK in green and then the US in blue show that we've taken much longer to get the death rates down. And indeed, this chart was finished on May 31st of May, and the US death rate has now threatening some days to go above where it was then. But now I want to switch gears to the question of community, but via the topic of liberty. It seems that while some market fundamentalists have turned market worship almost into a kind of death cult commitment to sacrifice for the economy, the language of liberty can be used in very different ways. So MSF, that I was highlighting before, Médecins Sans Frontières, their campaign to free the vaccine invokes freedom in a very different way. Freedom, it's worth a shot, they say. A free COVID-19 vaccine is the only way to keep everyone safe. And they have a campaign around freeing the vaccine, talking about liberty in terms of access to a medical therapy when it comes through, that will ultimately lead to health for all. If you're interested in those kinds of arguments, I want to also recommend some other resources here, not just MSF Access, but UAEM, Universities Allied for Essential Medicines, which campaigns on this issue, and Knowledge Ecology International, led by Jamie Love in Washington, DC, who has been a terrific legal advocate of overriding drug company monopolies, and has on his site, or KEI has on their site, and a lot of important information about the override capacities, both nationally in the United States and internationally at the WTO through the so-called Doha Declaration. That's thinking about community and immunity at a global level. But as I said at the outset, COVID has given us lots of examples of community care and mutual aid at the local level. The clapping for health workers in New York City and across the UK is one example. Community care campaigns by Asian Pacific Islanders, by Sonoma County offering childcare for essential workers, all kinds of thank yous and claps for essential workers, both in the United States and internationally. We've seen groups like Oxfam arguing that pandemics know no borders, and so neither should compassion. And in poor countries and communities like Vietnam or the Kerala state in southern India, we've seen relatively impoverished local governments and communities successfully battle COVID with innovative forms of community cooperation around the basic public health measures we've been asked to follow here in the United States, including testing and contact tracing to break the chain of the disease. I want to switch gears now from those lessons about community globally to the lessons for UCSC of COVID. We've seen examples of the university jumping into action to respond to the crisis and do something locally for our local community that makes a difference. One of these is the UCSC Molecular Diagnostic Lab. And those of you who are interested in this lab, that they've been set up by Jeremy Sanford and his colleagues in physical and biological sciences in conjunction with the Genomics Institute. Those of you who are interested in their work, there's an upcoming talk this Thursday, also at 5:30, a Craw lecture, where they're going to be talking about their setting up of this diagnostic lab and their partnerships with local community agencies, the Santa Cruz County Health and Salud para la Gente, amongst others. Other things going on campus in response to COVID include faculty and staff pursuing training for contact tracing, and ongoing partnerships that we have with the City of Santa Cruz, with Pajaro Valley Health Trust, HIP, the Health Improvement Partnership, and Salud para la Gente, all lay foundations for ongoing and growing partnerships going forward. Marcia Ochoa, the provost of Oaks College, in partnership with the Institute of Social Transformation, is building a bilingual training program for Spanish-speaking essential workers. And more generally, and going forward and longer term, I think there's a lot we can do with our education initiatives with and for these local community partners, including Salud para la Gente. And that speaks in turn to what we can do educationally at UCSC in global and community health. As you know now, there are plans underway for a BS and a BA degree that we will be seeking to get approval for in the fall. And these programs are being designed in a way that's deliberately interdisciplinary, building on courses which are listed on our website, and I'll take you there later in the Q&A period. Courses from all 5 divisions of the university. These are courses that also reflect UCSC's long-standing commitments to social justice. And because the determinants of global health outcomes really cross the spectrum from the disease determinants, the public health determinants, and more distal social and economic determinants, like racism, like debt, like militarism. Because they cross that spectrum, we need a truly interdisciplinary program to teach about global and community health. And COVID only underlines the importance of this. It's really underlined the importance of social determinants, both locally and globally, in structuring vulnerability. And I've highlighted just a few of the examples we can point to of this. We need more social science of unequal resilience and response capacity, the sorts of work that Rob Fairley's done, for example, that many other economics folks can do, but also politics studies of response. And my colleague, Sari Nedvecki in politics, is very interested in the unevenness of policy responses across Latin America in their capacity to respond to COVID. It's another thing that we can offer our students is an understanding of those varieties. At the same time, we can build on UCSC's terrific strengths in genomics, the Genomics Institute, which teaches, amongst other things, about the evolution of a virus like COVID as it moves across the planet. Genomics Institute work and David Hausler and his colleagues have been very strong right from the beginning also on the importance of sharing data freely internationally and not privatizing and locking up data as many drug companies want to do. There's a natural tie there to the campaigns for access to a vaccine, I think. And then the natural science of epidemiology, the sort of work that Mom Kilpatrick has shared with many people who are probably on this Zoom call too, and many of his colleagues in METEX and in MCD biology. Much of their work is vital for understanding the biology, the serology, the epidemiology of the disease. We also need political economic analysis of why treatment and vaccine access is going to get limited without political change. And folks in the humanities, in history, and in cultural theory and feminist studies offer terrific insight into the history of other diseases and in disease responses and the cultural politics of disease narratives. This disease, COVID, has also highlighted the value of building new tools, new apps, and also not just engineering here, arts, and the work of developing documentaries about disease. All that's made clear by COVID. And I think the university, by pooling the strengths of its 5 divisions, can really respond to these lessons and deliver a global and community health program that's very powerful and useful for our students. Now, our students are already doing work in this area, and I want to link here to some of that work that Nancy Chen in particular has been a leader in organizing these health well-being awards. Let me link to that now. I have to share a different screen. Okay, and you see some of the awards that have been given to our students for their work in relation to global and community health, including Avir Elor's engineering-related work towards immersive media for emotionally intelligent virtual reality healthcare experiences. I also want to flag here 2 students with whom I've been working, Manya Balanchanda and Rushi Saharan, who are doing a terrific survey project on the health needs of homeless women in Santa Cruz, and who hope to publish an article based on that work. I flagged that in part, and I'll go back to my PowerPoint now, and one more slide in order to highlight that our education initiatives on campus in global community health can only work well because we have such a terrific series of expertise clusters on campus in genomics, in microbiology, in environment and food, on all the different social determinants of health, including housing and lack thereof, in community studies, and our incredible track record of training people who go on to be community health leaders, like Barbara Ferrer, who's currently leading the LA County public health response to COVID. Across all these areas, we have real wide and deep talent pools on the university campus in our faculty. And this starter draft page of listing some of these expertise clusters is also available on the Transform UCSC webpage, where you can see direct links from this page to the various faculties' work. But I want to end this talk here by talking about how we need to seize the opportunity of this pandemic. One of the things that became very quickly clear as those of us working on global and community health program design started to assess where our expertise clusters are, is how many connections there are between them. This Venn diagram here really is showing points of intersection. And when we listed names of faculty under particular categories, one of the problems with this chart is it doesn't show how those categories actually overlap. For example, how do non-communicable diseases and diagnostics researchers relate to women's health? There are really important links here, and people like Professor Vasquez cross over into multiple categories, and this is the same for many faculty. So to seize the opportunities of those kinds of synergies, I think it is a really it's a big challenge, but also a big opportunity for this campus right now. And I think that COVID is pushing us to realize that opportunity and rise to the challenge. One inspiring quotation that I find particularly useful for thinking about seizing these opportunities comes from India, from Arundhati Roy, a wonderful writer, who reminds us that historically, pandemics have forced humans to break with the past and imagine their world anew. This one is no different, she says. It is a portal, a gateway between one world and the next. We can choose to walk through it, dragging the carcasses of our prejudice and hatred, our avarice, our data banks and dead ideas, our dead rivers and smoky skies behind us. Or we can walk through lightly, with little luggage, ready to imagine another world and ready to fight for it. And so when you see this Fiat Health logo that Cora Fortune drew for our nascent global and community health program, think of the slug going through the portal and caringly carrying a globe through it and trying to think about how we at UCSC can contribute to imagining a better world, a utopian world beyond the dystopia of COVID. So with that image, I'm going to close my screen share and open this up for questions. So.
Great. So I just want to say thank you so much, Matt, for this wonderful and comprehensive presentation. And we have questions from the audience. What I'd like to do is I'm going to try to sort them from specific to more general. And let's see, let me begin with some more specific questions. With regard to the slide that you showed comparing the success of male-led countries to the female-led countries, are there differences in the language and or interventions that were employed?
Yeah, of course, it varies immensely. And it's somewhat of a polemical graphic showing that the countries led by women have done better than the countries led by men. It's simplifying, of course, and there are huge variations between all those different countries. But one of the things that I think has really demarcated and differentiated the more successful response countries is their respect for science and scientific expertise, and they're associated with that a real recognition of the need for collaboration, not a gung-ho, go it alone, I'm in charge kind of attitude. And while that sounds a bit simplifying, it nevertheless really tracks onto differential responses across all these different countries. Respect for science and a recognition of this need for collaboration, and including international collaboration.
Great, thank you very much. This actually reminds me very much of the 1980s at the onset of this pandemic, where the response to HIV/AIDS there was very much a geography of blame. And so there's another question from the audience that talks about, it's very interesting in your response to the first one, you talk about the importance of science. Another question from the audience concerns how diseases have been politicized. And they specifically mentioned, for example, HIV. And the audience is asking, has there been a disease outbreak with such an egregious anti-science backlash that hampers response? And is there research on that? And then what to do about it? So this is, I'm using wording directly from the audience and how the question has been posed.
Well, it's a really great question. And there's a good literature on what Paul Farmer, the anthropologist and physician who's famous for collaborating to create the NGO Partners in Health, is a great book by him called AIDS and Accusation, Haiti and the Geography of Blame. And it certainly highlights that the case of AIDS was another case where initially, at least, blame narratives took precedence over a scientific response, an expertise, a medical expertise-based response, and a caring response to the disease. And in his own analysis, in that book of the blaming of Haiti as the origin country of AIDS coming to the United States, basically, Farmer highlights he's not just critiquing the geography of blaming Haiti, but he offers an antidote. Not surprisingly, perhaps as a physician, but he offers an antidote in terms of cultural anthropology, basically of highlighting the circuits of travel and economic interconnection and interdependency that actually meant that sex tourists from the United States brought AIDS to Haiti. But he doesn't want to sort of replace one geography of blame with another. He wants to say, we should be focusing on all these interdependencies. What makes a country dependent on sex tourism, what then makes it vulnerable to the takeoff of a disease, and so on and so forth. And the blame should be put rather on how we have structured the interdependencies with inequalities and blame narratives that ruin our ability to respond. I do have a slide that talks to geographies of blame, and it has a great quotation. So let me just share that quotation with everyone. This quotation is another historical example of blame shifting. It comes from Roy Porter's massive book, The Greatest Benefit to Mankind, which is basically a history of medicine. And in this book, Porter at one point talks about the history of syphilis. And this is, a really kind of telling example of how what unites human beings in terms of vulnerability ends up becoming something that is used to culturally divide and undermine a collective response. He's talking about syphilis here and the blame shifting around that. And he says, initially it was called the disease of Naples, but rapidly became the French pox and other terms accusing this or that nation. The Spanish disease in Holland, the Polish disease in Russia, the Russian disease in Siberia, the Christian disease in Turkey, and the Portuguese disease in India and Japan. For their part, the Portuguese called it the Castilian disease, and a couple of centuries later, Captain Cook, exploring the Pacific, rued that the Tahitians called the venereal disease Apa no Britannia, the British disease. He thought they'd caught it from the French. So you really have a sense there of the long history of blame shifting around disease. And now we have it again with COVID being called the China virus, the Wuhan virus, or Kung flu, and President Trump's more recent experiment with another critical term. And the antidotes of following in the footsteps of Paul Farmer, or the kind of critical cultural analysis of a historian like Roy Porter, are many. And we can turn to genomic science to actually track the origins of a disease and how it changes as it moves from around the world. We can offer the kind of environmentally sensitive epidemiology that Mom Kilpatrick and others at UCSC work on. And we can offer international political economy analyses of the connections that create the pathways for the disease to move along. These are all antidotes that I think are really useful. So I'll stop the share there.
Great, thank you very much. You actually, in this comprehensive answer, you anticipate some of the questions that other audience members have raised. And this is actually, instead of staying with social science right now, I'm going to go to UCSC specific questions. One of the audience members is asking, what makes UCSC better suited for addressing the COVID-19 pandemic compared to other research universities? And how, what might other universities, research or not, what can they do to become better suited and accommodate students or staff in the process? So this is both on the one hand, a uniquely specific UCSC response, which you've outlined some of the incredible researchers and knowledge that we have here. And then how might we be able to, be a model or example for other campuses?
Yeah, it's a great question, an opportunity to talk about the UCSC specific sort of advantages or synergies that we have that enable us to make a response. I wouldn't say we have any better an opportunity than other universities, but we have a distinct one. I mean, many other UCs are offering a lot. Berkeley also has a testing lab. It's set up, and they have terrific strengths in epidemiology. And UC San Diego is doing really interesting stuff with engineering and apps for contact tracing. I mean, so people at Merced are doing interesting work around migrant vulnerability. There's terrific work being done across all 10 campuses. And I do want to flag here the leadership of the UC Global Health Institute in helping all the UCs to pool what they have and see that they can actually work more effectively if they work together in global and community health. I guess though, finishing that last sentence with that word community. Community health has not been such a big thing in UCGHI's work, and it is one of the distinctive ways in which we have framed global health at UCSC, bringing the concern with community, including our local Californian community, to discussions of global health. I think that's a good antidote to the sort of biomed overinvestment in magic bullet kind of ideas that sometimes you see at places where a medical school is driving all the global health research. And one of the concerns of my colleagues back at UW in anthropology and even in the global health department was that it was often too biomedical a response and not addressing the social and cultural and economic determinants of health. So because we don't have a medical school, you can see that very much as a glass half full, in that we have an opportunity to articulate UCSC's long-standing interest in social justice and commitments to social justice, its long-standing interest in community work, and community studies, with the wider work in global health. And to that we bring, I mean, there's many other resources. We've got all the work of David Hausler's team and Jim Kent and others in the Genomics Institute. We have Jenny Reardon's leadership of the Science and Justice Research Center, which builds on the science studies reputation and great history here, with people like Donna Haraway being incredible luminaries in science studies. I think, just to come back to the difference of UCSC, because we don't have a school of medicine, because we don't have a school of public health, there's not one big kind of guerrilla kind of trying to control the agenda. We can really collaborate between all 5 divisions more effectively in global and community health, because there's not this one outsized kind of player trying to seize the agenda. So I think that's a real opportunity for us. Last thing I'd say is to echo a point that you've made, Nancy, and I should let you speak to this more, but sort of one of the things that you highlighted right from the start, since I started talking to you about global and community health, is that we live in a place that's sort of halfway between the wealth of Silicon Valley on one side and the poverty of the Pajaro Valley on the other side. We're in a sort of a unique position that way to be a bridge and a communicator between these valleys of inequality. Paul Farmer talks about mountains beyond mountains as a kind of a watchword for global health, always thinking about the distal causes of illness. And I think we can think through the lens of our own valleys, thinking of valleys beyond valleys as a way of connecting wealth and research and opportunity with making a difference in impoverished communities for vulnerable people.
Thank you very much. Actually, I'm so grateful that you brought up this issue of the being between 2 valleys. And I think another significant part of the work that our scholars and university researchers are doing in collaboration with community is realizing that it's not so much that communities are impoverished, but it's more about being underserved. And so there are ways in which we can think about communities as being very resourceful, despite not having access to resources, particularly with regard to health equity. What I'd like to do is actually kind of combine 2 questions that seem somewhat related, and this is actually about epigenetics. So we have a question from the audience, and I'd be happy to join in on this. One audience member says they wonder if there's going to be a need for research through epigenetics on the traumatic impact of future generations. But a somewhat related question that's more specific, and we might talk about the resource knowledge base of our campus too, with regard to soil health, animal health, and farming. The fact that we have the CASFIS, the Center for Agroecology, is an incredible resource. And so I'm wondering if you could also talk a little bit about, and you do include this in a graph that was in your slide, about the notion of whole health rather than just simply a biomedical vision.
Yeah, I mean, obviously I'm not an expert on epigenetics at all, but it's a really important field in medicine and in public health now. And it concerns the so-called epigenome surrounding the genomic data that we pass on. And researchers are showing that damage to the epigenome can create inheritable damage, and it's passed on to the next generation. So if your parents conceive and give birth to you, and when they're living next to a toxic waste dump, not only are they at risk of cancers, but then that risk can be passed through the epigenome to the next generation. That's one of the big areas where I know epigenetics speaks to questions of vulnerability. It's often racialized vulnerability too. And yeah, the flip side of those patterns of causality is that just as structural forces like environmental racism can become embodied at a molecular scale, so can community care and organic agriculture and things that we do to improve our environment become embodied in our molecular makeup too. So it works both ways round, and it underlines the importance of the kind of work done at the farm on organic agriculture, the kind of work done around our researchers, including people like Julie Guffman, looking at the challenges of actually practicing in organic agriculture in a very competitive global economy that's always trying to drive down costs and so forth. And so all of that, I think, can inform an approach to health that is, whether it's through epigenetics or something, or another kind of analytical lens, looks at processes of social and causality as becoming embodied in our actual makeup as either variously ill and healthy people. And we really do have, I think, at the farm some terrific capacity to sort of advance work on what builds, more healthy people. And people like Tim Galano are working, of course, on how we help our students eat healthily while they are students and not, many of them are facing food insecurity, but how can we leverage the farm to actually help our students eat more healthfully?
Great. No, thank you very much. Not only for the shout out to the farm, but also we have this fabulous coastal science program that just got started about a year or two ago. And so, we're very, very fortunate to be in a place where it's not just the land, but also the oceans, and the focus on ocean health is also just as important for epigenetics. I have a few questions that have come up from the audience, and this is turning back towards the pandemic and the vaccine. And in your overview of various research related to COVID, and you had a specific slide related to the vaccine and the concerns about how a privatized vaccine or a for-profit vaccination program can be incredibly harmful. But this question is more about what are some long-term social effects the world may feel even after a vaccine is found. We currently have multiple companies exploring and doing different testing at the moment. And in other words, so it's a two-tiered question. What are the long-term social effects, even if a vaccine is found? And then how might these effects be different than other pandemics? If we compare it to, say, the SARS pandemic or other types of epidemics, what is it about pandemics and social forces that are important to pay attention to?
Right. Well, it is depressing to read headlines about how even in the face of COVID, many people in America are deeply skeptical about vaccinations and are prepared to join anti-vax kinds of campaigns of one kind or another. And clearly one of the longer term problems that needs to be overcome in America, and it calls for social science as well as public health research, I think, is what explains this deep sort of skepticism and fear of vaccination, and how do we overcome it? Because, I mean, this is where the language of herd immunity has been sort of corrupted, particularly in the UK, by Boris Johnson's government in talk about COVID, and this idea like you kind of get enough people sick and then you get herd immunity, which is not the way it's normally used. The idea of herd immunity is normally used in public health around promoting mass vaccination programs. And you create enough protection at the society-wide level ideally a global level, that you stop the diseases in its tracks, as was done with smallpox. And so we need to address all the things that limit people's uptake of vaccination. And clearly there's this deep resistance that's emerged. And I think it calls for explanations and research. And I would offer a few sort of speculative reasons why there is so much resistance. I think it comes from multiple angles. There's the sort of anti-science, anti-expertise kind of populism that we see on the far right, but there's also distrust amongst many people of science, in part because they see it as being co-opted by for-profit interests, and so there's a sort of ironic, double damage, if you will, from the kind of drug company profiteering. Because if people just see what drug companies are doing as all about making profits, they think, well, why should I, pay any money, or why should the government pay any money for this vaccine? And then amongst certain racialized communities, there's a long history of testing and that's put them at risk, and of mistreatment, misdiagnosis, that makes people in opinion polls express a great deal of skepticism about vaccines. So I think we need more analysis of those kinds of explanations. Let's see. I think that's one way forward. There was another part of that question though that I'm missing.
Let's see. So I was merging two questions, and so you answered in many ways the first part of the question, which is what might be long-term social effects that might be felt even after a vaccine is found, and then the second part was really how might these effects be different than any other pandemic or previous pandemics.
And and on that note, you just think, well, COVID is so extreme. It's presented such a calamitous global crisis. Surely this will make people think again, think anew. I mean, Arundhati Roy is really onto something. I think we're saying this is like a portal. And I think it is making people think again. It's teaching people not to take medical breakthroughs for granted. Maybe it will force people to reevaluate their resistance to other vaccines, because it has reminded so many people how and this is why I think the language of being in it together is not without merit. It has reminded us of our common vulnerabilities, even though they're unequally distributed.
Mm-hmm.
And if people can recognize that taking a vaccine is protective, not just for themselves, but for their extended family, and for many other people in their community. I think COVID's a sort of prompt to think that way that they might have been lacking in the past.
Mm-hmm. Yeah, and in many ways, I think your response to this query reminds me so much of our alumna, Laurie Garrett, who is the science researcher and writer who won the Pulitzer Prize for her book, The Coming Plague, right? And that book came out 2 decades ago, and in many ways continues to anticipate different scenarios, different ways in which how not just community and personal responses to COVID, but also global health responses. I think she has gone on, of course, to do research on Ebola, on multiple other types of pandemics. And the media, of course, talks about the fact that people might be wearing masks for quite some time, that this is another social effect where we might learn to wear masks or not. That might be another aspect. I'd like to, in the remaining time, turn to a couple of questions that have popped up since your response. And one of them is about, according to the data that was presented, the minority versus white disparities in death hospitalization rates is much greater than the disparity in infection rates. And what are the factors that might account for this? So if you can go into detail about there's infection, but then there's people who will survive infection or may be released from the hospital after being tested, no longer being tested positive for COVID-19. Why is it that there's such a disparity in the minority versus white rates?
I think a lot of the detailed work on this still needs to be done, but the basic factors that I highlighted are key causal mechanisms, the pre-existing medical conditions that put African Americans, Latinx, and Native Americans at extra risk are big factors in accounting for the extra, death rates and hospitalization rates. Underlying conditions like diabetes and asthma and hypertension, often in combination with one another, making it harder for people who get the disease then to fight to recover. There's multiple complicating factors, of course, including the medication regimes people are on, and that's where ongoing analysis is needed. And as Mom Kilpatrick pointed out in his talk a week or so ago, the death rates do lag the case rate reports. So, right now we're seeing this explosion of cases in Florida and Texas, and sadly in California here too as well. And we won't see the sort of differential death rate sort of outcomes of those case explosions for probably another 3 to 4 weeks.
Mm-hmm. Yep. No, I'm so glad that you are pointing out the fact that we are still just dealing with the frontline work of hospitalizations and the analysis of forensic data. They've only started, I remember reading in various scientific journals about going back to look at forensic data from December, for instance, as well as looking at public health infrastructure, analyzing, fecal content in drain pipes that, back in even earlier than December, just to see, if COVID-19 was existing long before. So I think you're absolutely right that right now a lot of information still needs to be sorted through, and we need to do much more careful analytic work. I'm hoping we might be able to end on as we're running out of time, on a slightly more upbeat note, which is really to ask, how might global community health address local community needs as well as global health? In other words, there have been a lot of questions coming up from the audience asking, what is global health precisely? How do you measure it? How does it work? And then, so maybe if you can talk a little bit about your expertise in global health for these many decades, and then what types of intervention we're hoping to make with global community health.
Oh, thanks. Well, I don't want to claim too much expertise in global health, but I've been trying to contribute to it over the last 10 years at least. And one of the things that it differentiates it from preceding regimes of colonial health, international health, is that it combines sort of 3 different dimensions all at once. It combines a concern with prevention and public health measures with treatment. And so it sort of combines both the public health tradition with the more biomedical intervention treatment traditions. And it combines those 2 elements, prevention and treatment, with a third concern that was particularly characteristic of post-colonial states as they emerged from colonialism in the middle of the 20th century. Global health inherits the commitment to health for all, for equality in health, after the kind of double standards, the asymmetries of colonialism, where colonial health administrators tended to only concern themselves with the health of colonial armies, and only cared about the workers if they were in the mines or plantations that kept the empires going. And post-colonial health really, as Randall Packard, a historian, teaches us, that rejected that double standard, obviously, and global health then inherits this kind of commitment to health for all that was articulated most famously in 1978 at Alma-Ata. And it's in turn that commitment to health equity, of health for all, that makes it possible to combine global health with social medicine and community health practices in particular countries like the United States, where community health has always been concerned with the social and economic determinants of health, and how poverty and homelessness and so forth, nutrition, are part of the health picture, not just diseases and not just treatment in hospitals. So that kind of creates the possibilities for putting global and community health together. I think we've already talked about some of the intellectual resources we have on campus for doing that, but what I haven't addressed so much is our opportunity, but also our fortunate sort of need to learn from our own community. And that goes back to something you said, Nancy, about not saying that poor communities are necessarily without resources, that without the capacity within their communities to know what needs to be done. We need to learn from those communities about what they're already doing and how we can join with them to be effective partners. Cindy Larive, the Chancellor, recently invited me to represent UCSC on the board of Salud para la Gente. And in talking to their leadership, it became quite clear that one of the things they're really interested in is creating pipelines for education, so that community health workers who want to work with their own community can nevertheless get the training they need in order to then deliver the benefits to their community. So if we can be a partner locally with Cabrillo College and other educators, maybe high schools, to create a more conjoined up pipeline of global and community health education, I think it would really be a wonderful way of contributing back to the community.
Great. Thank you very much. We're actually right at about time, and I'm going to hand it over to Nicole. And I just want to thank you so much for this fabulous presentation and conversation addressing all these great questions.
Well, thank you so much. And thank you everybody who's joined.
Thank you, Professor Sparke. Thank you, for Professor Chen, and thank you all for joining us tonight. Please join us this Thursday, July 23rd, for our next crowd lecture that Professor Sparke mentioned in his presentation, COVID-19 diagnostic testing, with the Assistant Professor Elena Vasquez, Professor Jeremy Sanford, and Professor Matt Stone. Good night.
So thanks so much, Nancy. You're a great